For those of you who don't know me, I'm John Staley. I'll just take a few minutes to go over a few housekeeping items in terms of the slides, the recording and evaluation survey. It'll be available on the NC OSHRC and the Carolina Center for Healthy Work Design and Worker Wellbeing websites. We will also put the link for those in the chat, and I suggest you bookmark them for future reference. And again, we greatly appreciate you taking the evaluation survey at the end, and there'll also be a slide on the screen at the end that shows a QR code that you can scan. It's a very short survey. And it's important to note that only those that are formally registered for each seminar receive the follow-up emails and information. So just make sure that you register for the future webinars as well. Importantly, things are popping up on my screen left and right. If there's anyone who wishes to claim attendance credit for the seminar, including either NIOSH trainees or you need professional certification credits, make sure you complete the evaluation survey within 2 weeks. So next slide. So jump in just briefly here, tell you about the Carolina Center for Healthy Work Design and Worker Wellbeing. Next slide. Our goal is essentially generate new knowledge, worker health, safety, and well-being in North Carolina, but also the southeastern part of the U.S. and nation as well. And we have been excited from the beginning to have particular focus on essential workers and looking at these working conditions that, particularly since we've seen so many come out in the forefront in the news after COVID, the impact of working conditions on health outcomes. So if you're not familiar with Total Worker Health, which we are a Center for Excellence for Total Worker Health funded by NIOSH, this is Total Worker Health is any of your policies, programs, practices that integrate protection, your traditional protection from worker safety and health hazards, with promotion of injury and illness prevention efforts to advance worker well-being. Because if you think about it, the workplace is a social determinant of health. So we want to do all that we can there. Okay. So this slide just shows we are one of the 10 Centers for Excellence in Total Worker Health in the nation. Next slide, please. And then briefly, the North Carolina Occupational Safety and Health Education Research Center is one of 18 NIOSH-funded education research centers. And this is our goal, to provide high-quality education. So we train a variety of students. And while we are physically located at the University of North Carolina, Chapel Hill, the Gilling School of Global Public Health, we have academic programs at UNC, but also Duke University and North Carolina State University. And we also provide a variety of continuing education courses and outreach services through both centers. And we are one of the longest standing NIOSH-funded ERCs since 1976. So again, if you need a certificate for continuing education or CM or CM points, again, within 2 weeks of the live seminar, make sure you've completed that evaluation survey. You can email OSHRC directly to request a certificate, and then we'll be happy to send that to you. Next slide. And just quickly, I want to show you, and these slides, again, will be available on our websites. We have upcoming Spring Institute continuing education courses here in Chapel Hill at the lovely Rizzo Center in Chapel Hill, North Carolina. So respiratory protection fundamentals, biosafety, industrial hygiene, industrial toxicology. So we want to make you aware of that in May. That'll be coming up. So the last thing here, and again, you'll see this again after the webinar, but that's our next webinar information that will be coming up in May, on Tuesday, May 14th with Dr. Sean Knight. But today I had the pleasure to welcome Dr. Lucas Mazer. He is a co-investigator on the Carolina Center for Healthy Work Design and Worker Wellbeing's research project on rural and urban clinician well-being. And we know, again, big issue that emerged to the forefront during the COVID pandemic. Dr. Mazur earned his BS, MS, and PhD in Industrial Management Engineering from Montana State University. And he is a professor in the School of Medicine with a joint appointment with the School of Information and Library Science at the University of North Carolina at Chapel Hill, and director of the Division of Healthcare Engineering at UNC Chapel Hill as well. And his research interests include engineering management as it pertains to continuous quality and patient safety efforts in healthcare, as well as human factor engineering with a focus on workload and individual performance during human-machine interactions. So with that said, I'm going to turn it over to Dr. Mazur, and he will also introduce our wonderful panelists that will be participating as well.
Thank you, John. And just double checking you can hear me well, and you guys can see me as well.
We can hear you. And let me check the video.
All right.
Yes.
Appreciate that. Yeah.
Mm-hmm.
Okay. Well, thank you for that. And I apologize coming a few minutes late. My heart rate went to about 160 because, technology. So as we tested yesterday, everything was working. Just as usually, my computer would not collaborate. So I'm joining you guys from my phone, but it worked out. So I'm glad. My heart rate is coming down from trying to fix it over the last 10 minutes or so. But I do truly appreciate the opportunity for being able to share some of the thoughts and results with you guys today. And also want to, thank the center for having us and everybody, being here. And especially, want to thank our panelists for agreeing to be here with us and share kind of more contextual perspective on some of the results we will be presenting. So again, big thanks to everybody. So thank you, John, for the introduction. I do want to introduce two panelists. So we have Dr. Nadia Charguya. She's an associate professor in the School of Medicine, and she's also our director for the taking care of our own program here at UNC, and also an executive medical director for UNC Healthcare's integrated well-being program. So we have Nadia. So thank you for being here, and also I have Shona Buchanan, experienced nurse, as well as with a lot of talents. I've got to know Shona over the last few years, so please know in terms of communication, what I kind of like to also talk about creation of content in VR, which we've been of virtual reality, and kind of doing some really amazing, almost Hollywood-like production for us here when we develop training and other things. So Shona has a lot of great talents. She works with me in our division of healthcare engineering, creating some of that content. So before we move forward, I wanted to offer both Nadia and Shona to just talk a little bit more about their expertise in the field and what they're leading. So Nadia, if I can start with you, that would be great.
Yeah, well, thank you for the lovely introduction, and wonderful to have the opportunity to be here. So as Lucas had mentioned, my home is within the Department of Psychiatry in the School of Medicine, and have initially got introduced to the realm of well-being, perhaps one through my own lens of burnout, but then additionally in working with our program, the Taking Care of Our Own, which was a very grassroots-driven program, was developed first in 2012 to address just this trend of burnout that we started to recognize, initially was specific to our physician population, those in training especially, but has expanded to all of our healthcare teammates. Truly, that program continues to keep me just so grounded and informed in looking through the eyes and the experiences of so many of my colleagues, and continuing to see that improvement is needed, and wanting to be able to help with those improvements. So through that work, I was inspired to grow into these other roles and to expand this other work within the well-being realm, as Lucas had mentioned, but so pleased to be with all today.
Thank you. Thank you, Nadia. Appreciate it. Shona?
Yes, thank you, Lucas. I'm excited to be here. So I became a nurse in 2017, and I started my career at UNC in the surgical trauma ICU. So it was a bit before COVID. And then when COVID hit, I started working as a COVID ECMO nurse on the unit. So it was, I'm sure we'll get into it later, but that it was quite a time to be a nurse, and especially working directly with COVID patients. And then, as Lucas said, I also have a degree in film before nursing. And so we're looking at some of the things that we can use film and virtual reality for in the well-being or empathy training realm. So.
Yes, thank you guys. And I'm extremely fortunate to have a chance to work with both of Nadia and Shona over the last few years, as they're leading a lot of very important efforts, and the energy is so thank you for being here. Let's go to the next slide, please. So just to place us in the right order, this particular work, and what I will be presenting some results today, and really initiating discussion with our panelists and really with all of you. And we really hope for some engagement and questions or comments from all of you. But please notice that at the bottom of the slide, you see the 3 pictures and of our team, of one of the project number 2 that was awarded through the center, really focusing on the idea of utilizing this new tool that came from NIOSH, the NIOSH WellBQ, as part of our proposal, is to really kind of go in and understand the differences in kind of the holistic way we think about well-being, the burnout, all the topics which are really large and complex, and collect the data with the idea of look to the differences between rural and urban settings, and also physician versus nurses, right? So we've been very, very fortunate to receive these R21 level grant funding and initiate this work. And as we know, working across multiple entities over time is always very challenging, from a perspective of IRB and coordination. So we've been very fortunate that this project has been slightly extended, but really going well for us. And I do want to, say big thank you to the center and Laura Linden for supporting us, and everybody really, Maja and so many people in the center that really made this happen, and really allowing us to do this important work. So thank you. Next slide. So what the purpose for today, really the objectives that I would like to hit. We have 2 bullets. One, I want to speak to the validated frameworks that have been created, developed over the years. One's going to come from National Academy of Medicine that we've been using for studying burnout and the factors. And the second one with the new tool that has been recently proposed by NIOSH. So that will be one. We'll go over this. And then I'm going to present results. Please, for the audience, this is the first time we're presenting these results. It's very fresh. You're getting virtually an initial look at some of the aggregated results from our data set. So I'm actually very excited to see what questions and what comments you guys might have for us, because this is actually very first time presenting. So this is exciting, even at all levels. But I'm very excited to see kind of what's going to happen. We're going to have very informal presentation. I'm going to be presenting some results and asking our panelists to comment, and then really bringing you guys all for more questions. So please use the chat. Please kind of engage with us in this conversation. Next slide. All right, so let's kind of start. Being an engineer, and in this case, an industrial engineer, I spent my education really thinking about systems and looking at different tools, methods, and approaches that we can do this. And I really love working in the healthcare. I've done it starting, back, 25 years ago when I started taking internships in the healthcare, thinking that working in the hospital would be more fun than maybe in a factory, as I was kind of learning about manufacturing a lot in school. I spent 5 years at NC State, the red collar guys here, within our state. Traveling around the state and doing a lot of projects kind of through the extension service, and learn a lot, and really been, I feel like I've been in every corner of the hospital. And what we have here is really understanding that it's a very complex system, right? We're dealing with a very complex system with very sick patients, having a lot of complications, a lot of processes, team members with so much expertise, different kind of degree of coordination that is needed. And we really strive for high reliability in the healthcare as aspiration, but we are definitely set differently than other high reliable systems that we study, right, in our kind of engineering. So it's a very I want to bring, we are talking about very complex system. And when things go kind of wrong, and we think about well-being and burnout, we definitely take into account, all the levels, right? We need to think about the individual itself and how does it really affect him. But then we look at the, the team and organization and so forth. Yes, let's kind of go to the next slide. So the first model on the next slide is what was given to us, for over a decade of how can we look at burnout. It really came from our National Academy of Medicine and really gave us this perspective that we really, going from the left, from kind of the circles, we need to look at the healthcare delivery, and we need to look at our individuals and the teams that are organized to do this. We got to know and understand their workflow, their processes, and what is affecting them. The next circle round, we need to take into account that these individuals and these teams that are different, they live in organizations that have different norms, beliefs, and there's a culture that kind of definitely, right? We can definitely distinguish that there are sometimes cultures different within units versus the culture that the organization as a whole, and sometimes healthcare systems have. So there's so much interaction going through these levels, all definitely surrounded by the environment. So when we think about environment, and this is where the policies, kind of how the healthcare system as a whole, the logistics and all the rules are being set up, including insurance and everything else, it all affects, these individual factors. So what's really was important from National Academy of Medicine, that they gave us a set of factors to start in terms of what are the job demands and what are the job resources that are kind of there that are affecting the individuals, as you can see in kind of the zooming through this lens. And those individuals, which also have their individual factors, they will be, through this model, affecting the burnout. And as we can say, this is a circular motion. But the good news was that we did receive these lists of starting points. So when we think about job demands, for example, workload, administrative burden, workflows, time pressures, right? Job demands are out there, and we can kind of have a starting list from this model of what to investigate and how to compare and contrast. On the other side, we have job resources, right? The meaning of work, organizational culture, job control, flexibility, reward systems, all these things that kind of we use as our resources to get motivated. Again, we can use those to evaluate, assess, compare, and contrast. And if we understand these, the idea about the model was that if we understand the job resources and demands, it better understands to predict, of how they are associated with the burnout, right? So this model has been in use for many years. It's been very popular, in a variety of communities, medical communities, nursing. We also had it in engineering communities as a starting point for helping us, guiding us about, how to assess the systems and then make changes. Let's go to the next slide. So as we move forward, we have now a new model, which is really exciting, from NIOSH. It's called kind of NIOSH WellBQ. And it's kind of in the, let's say, in a infancy state in a sense. It's a very comprehensive look at the idea about the well-being. And this is kind of what I would like to say important. The different way of looking at it is not only through job resources and demands, but really taking a very full holistic approach to the idea, right? It's a fairly lengthy survey. We see on the website that it's, that it could be taken within 15 to 20 minutes, but, from our experiences, people tend to take a little longer than that. So definitely there's a little bit of that moment where, we put in that extra time requirements to complete these. But please also notice that these models, which include now evaluation of the physical environment, right? Safety climate, workplace policies, health status of the individual. We're looking at things of, your depression, your how much violence at work do we have? What is the sexual harassment that we'll be speaking to today? Very, very rich look into this topic. And all surrounded, as you can see, it's very important to notice on the picture that the model is surrounded by the home, community, and society as the fifth element. And it's actually really interesting because we all know that what we do kind of outside the work, so what societies we engage with. Is this a church? Is it maybe, that we like, kind of be with, helping our planet, and we are connected with kind of green type of initiatives. This all plays a role. So it kind of looks extremely holistically at the model of what is happening. But please note, because there's not enough available data to date, and this is still really being organized right now. What NIOSH is telling us is that eventually this idea is to use the data from this model to send internal to the organization benchmarks, right? So that's one. It's very important to know what NIOSH is telling us how to use this. So benchmark internal to the organization or this workflows as a whole, right? So if we have enough data, maybe we can start saying benchmarks for nurses, for physicians. Again, that's not yet available. We can look at the changes over time and impact of interventions. And I think that is so interesting that eventually with more data, and we'll be kind of going into this topic a little bit, how to kind of understand what intervention and how we would affect pieces of the NIOSH, right? So if you think about very specific intervention for, allowing people to get engaged more with resources for being more active or more diet, well, there's a specific section in the survey to address that, right? So there's that opportunities to be very, I would say, detail-oriented in selecting subsets of the survey for interventions. And the last thing, as you can see here, is to compare results between groups, which we will be doing today, within the same facility or workforce, or across organizations, right, of working populations. So we today, when I present results, we are kind of getting ourselves into this, and the point number 3, and we're going to be presenting some data in this case. All right, so let's go to the next slide and start kind of looking at some data. Also, really quick, let's do another couple clicks. Yeah, this was the animation there. So if we don't mind. I just do want to mention that in working with Nadia has been really, for the last number of years, we've been, in addition to surveys, at UNC, we've been also taking a lot of effort, making sure that the data that is being collected from the surveys gets presented in focus groups. And please note that we even published some of the work, very interesting, that some of the individual scoring in the surveys is being changed as being discussed in focus groups. So there's a very interesting dynamics when we present the data in group settings, when we bring nurses, physicians, and everybody together, how they kind of, while talking, how some of the perceptions individually can change in focus groups. And we do a lot of contextual inquiries. It's like shadowing, for the purpose of really understanding all of these factors and being able to present them after we shadow people and really get the context for them to validate and prioritize, right? So we really take this seriously, that at the end of the day, we don't want just to rely on the survey results, and we really do want to do more work before, and let that voice be given back to the people from the front line to validate and prioritize before we get into any intervention. So we've been very successful over a number of years doing this work within the well-being program, and really kind of taking, I think, that extra efforts to ensure that the data gets extra validation before we move forward. So next slide, and I'm going to start doing less talking, which I'm excited, and let our panelists to kind of come in. But just to make sure, when you look at the data, where is it coming from? So I just want to make sure that I go over this demographics for you. You're going to be looking around 220 responses in total that we will be presenting. It came about 93 came from our urban hospitals. And as you can see, about 58% of that data there on the top is coming from the rural setting. So we have kind of a 60-40 data split. A lot of course, we know we had, because as we work with nurses, this is how the distribution in the population is. So most, we have about 20% of the male versus female there. You can see by race, mostly, Caucasian. You also see that a lot of, some split on the kind of a status of being single, married versus divorced. You can see we have 70% coming from nurses, about 17% from physicians, and also about 10% from advanced practice providers, and then a little bit of a distribution in terms of years of work. So that's the voice, okay? So I want to make sure that you guys can place a little bit of where's the data coming from according to these, to these percentages. And now we're going to take a look at the first result. So please, next slide. I know it's busy and small font, but I'm going to take my time to explain this, and then we're going to stay on this slide and have a discussion. What I'm presenting on this slide from the top is going to be 5 very specifically selected kind of these job demands and job resources. You can see it starts on top with the staffing, it falls to inefficient workflows, interruption, distraction, and so on. I've marked the data on purpose. What you're seeing in the columns, there will be physician and nurse, and then there will be a column for urban versus rural, okay? The way you want to look at the data on this slide is that we divided the data depending on the scale. So for example, if you have a scale of 5 from strongly disagree to strongly agree, that's a 5 on the Likert scale. The strongly disagree and disagree will be coded as negative, okay? Intermediate will be the neutral score, and the positive score will be the strongly agree and agree. So that's how the scores have been divided, and you can see the percentages, okay? So in this case, we had scales of 5, so there's the consistency for the NAMS framework. And again, as you look at the scores, you can just start looking at the negative. So it doesn't look too good. If you can see, staffing, 75% of physicians and almost, 63% or so of nurses, kind of across. You can see the physician, nurse, urban, rural. We all know that the staffing has been very challenging. So a lot of negative scores. But I on purpose marked a couple places in red. And I really want to go to this first topic, on the NAMS framework here, that if you compare the results between the physician and nurses, and you compare the scores between urban and rural, you can see that there's a lot of statistical significance between urban and rural, and not necessarily between physician and nurse, which only came up to that one statistical difference in terms of interruption and distractions. So my first question to our panelists, kind of engage the audience, so why are we seeing this? Why, just kind of knowing that, there's a lot of challenges, why do we see that possibly these things are a little better, things are looking a little better in rural settings? So I will open it up, and maybe I will start with Shona. Why don't I start with you? I have it on the camera. I can see you right here.
Sorry, I was looking at the chat at the question and I missed what your question was, Lucas.
All right. I just wanted, I'm asking, so why do things from perspective of NAMS framework, when we look at these job demands and job resources, why things potentially look slightly better, right? Even though they all are challenging, but definitely the data suggests here that working in a rural setting could be, slightly easier, better from those job resource and job demands perspective. So I wanted to get your perspective and then ask Nadia the same question.
Yeah. So, I worked at UNC Main Hospital, so that I can really just speak to that reality for myself. It's a teaching hospital. There's a lot of working parts, a lot busier, we get a lot of the patients who come from the rural hospitals to our hospital. And so in my reality, with the staffing, you have to staff, there's more positions to staff. There's more workflows possibly to go through because we have residents and interns and everything in our hospitals that we have to work with. Administrative burden, there's a lot of different cooks in the kitchen, I will say, with our main hospital, and having to figure out, during COVID, it seemed like every single day we got a new memo saying, this is how you need to do things now. This is how you need to wear your PPE now. Oh, now you have to wear your PPE for 5 days straight. None of us could keep track of that. It kind of felt like a free-for-all. And so, yeah, I think that it just felt like an overwhelming sense of disorganization because our system was so large.
Yeah, no, that's a great point. I do want to extend the question also to Nadia. What is your take on that difference?
Sure, and I agree with everything that was stated. I think a sense that comes to me, just to put it through the perspective too, I think there is such a sense of community that is embedded within our rural hospital settings. These typically, to your point, Shauna, are smaller teams, folks who work together for a long period of time. If you look at the longevity of careers, this is these are teams often that trust has been developed and grown. And not to say that that doesn't exist in the urban settings, but our teams are fractionated. We deal with more of the part rather than the whole a lot of the times. And, I'm having some flashbacks based on the operational inefficiencies that you point out. But, sometimes being a larger system absolutely can work against rather than for both, on the end of the clinicians and all of our teammates, as well as, sometimes on the end of the patients, where things can become kind of more complicated fast. But I think for me, it boils down to community versus, that fractionated team-based care, as well as trust versus mistrust, I think feeds a fair amount of the differences that we see.
Thank you, Nadia. So guys, I'm going to expand this to the next piece here, just kind of as we're looking at this slide, and just kind of see the bottom of the slide, we have the burnout, and you can see this very similar pattern, right? But we're talking about the data from kind of asking people about emotion exhaustion, depressurization. The next few lines, that we have patient health questionnaire, that's depression, PTSD, and then we have kind of the Mayo, this composite well index. As we can see again, very worrisome results in terms of, the kind of percent negative. But again, the same pattern kind of persists, as we don't see many differences between nurse and physician. There's few, but definitely we are seeing a lot of differences in that burnout between urban and rural. And I do want to give us a little bit of a hope here that when we analyze clinically the data from depression and PTSD, please note that none of those scores, fortunately, cross kind of to clinically, right, on these averages, to clinically, kind of the significance of doing their intervention. So perhaps, even approaching, but that was at least some good light of good news here. But, going back, and Nadia, and I want to start with you. So burnout in general, it's not hard. It's always hard to measure. But we have a number of different ways of measure, of looking at it here, like multi-faceted, so to speak. But again, seems like the rural hospitals are experiencing statistically, less of that feeling. So what's happening?
I'll address that question. I do believe there is a question in the chat. First, asking were all of the nurses and physician respondents from the emergency department setting or from the whole hospital setting?
Yeah, most of the data in this case, guys, came from the emergency department. We did go to the emergency departments in these settings, and 2 units that were kind of emergency surgical, right? So we did go into the inpatient units, but I would say that probably about 80% of the data is being represented, from our EDs. Yeah, that's a great question. I should have said that in the other side. Thank you for asking that. That's an excellent question.
To address the question that you asked, Lucas, of course, I definitely don't have all the answers, and it's complicated, but the framework that you introduced beforehand, I think, just beautifully describes all the moving parts and so many of the factors when we think about the experience of burnout, given that is an individual experience. It's it's a symptom from a system. Need to get those 2 words perfectly. What are those causative factors, or what are those factors when we think about what helps to restore? I mean, burnout is a condition that is, truly describing a state of being emotionally exhausted. Our emotional resources are depleted. We just don't have any more to give. And over these many, many years, I think systems we're speaking specifically of healthcare, for my experience, but I know this is representative in, a number of systems. I think systems have been slow to recognize the role that they play. And when I think about the healthcare industry, we are one, and I'm not pointing to UNC because this is not unique to UNC. Healthcare systems and industry as a whole has been slower to recognize this is about system processes and system needs that we really need to look into. There's been a ton of awareness of burnout, as I mentioned, our program, since 2012 that we've had it, but a lot of that awareness had been driven towards an individual. I think it's really over these past few years that we've been looking harder with the system and understanding in order to truly impact burnout. We can't just load a lot of resources on the individual and send everyone to yoga classes and mindfulness. I appreciate both of those approaches, big fan. However, again, that's more so addressing that symptom. And there needs to be more data such as this that really looks to understand what is the system perspective, what truly are the system needs, how can we then design improvement aspects and measure, does this have meaningful impact that is then experienced at the individual level, which is a lot of the work that we've been trying to do and grow.
Yes, thank you, Nadia. That's a really important perspective. And Shona, just to maybe ask, in addition, because as we now look at this slide, and I know you guys been now kind of had a chance to stare at it and maybe kind of look for different nuances there in these percentages, but we do trust in our theories and methods, and NAMS gave us, so National Academy of Medicine gave us, and clearly right now you can see there is some level of association and trust that the negative scores, right, those differences that you can see between urban and rural, they do lead, right, to what we would hope the differences in burnout, just like the model says, just like the model predicted. So it just, for me as a scientist and as an engineer, this to some degree confirms that yes, if you truly in rural settings we are experiencing less of these job resources, right, these demands, and have better resources in this case, there are differences in this burnout scores. Clearly, so we can go in some setting, let's go to the rural settings to really understand this at the granular level, what's happening, because these folks are due. So Shona, just maybe, as you've been a nurse, you've seen colleagues working maybe in different settings. Can you kind of speak to that, if you compare really colleagues that work with you in kind of medical, main centers, and maybe the colleagues you have kind of working in more of the rural settings that we have, can you sense that difference? Have you been able to kind of practically see it while speaking to colleagues, Shona?
Yeah, I mean, as I was looking at the data yesterday, I was trying to think about, why those numbers are what they are. And thinking back to my time in the surgical trauma ICU unit, like I said before, when patients get serious enough in the rural hospitals, they send them to us. So my thought is that patients still get sick in rural areas. They go to the hospital, and then when they get to a certain intensity, they get sent to the main hospital, and we take care of the sickest of the sick. And sometimes that can be a little bit harder to manage. I will say, when I was a nurse and COVID started hitting, and I said I was a COVID ECMO nurse, which means they're put on a special machine where we oxygenate their blood outside of the body. And so it's a pretty intense situation. You cannot leave the room. They could possibly pass in a mere seconds. And you have to be, normally ECMO nurses get trained. They get like an 8-hour training, and then they have 5 shifts where they precept with the ECMO specialist and a ECMO nurse. And when COVID started hitting and they said, Shawna, hey, you have to be an ECMO nurse now because we have too many patients being put on ECMO and we don't have enough nurses to cover, and only a specific number of nurses can do it. They gave me 5 minutes of an overview to be an ECMO nurse. And then boom, I was an ECMO nurse. So the amount of stress that I was under, starting from that day, trying to figure out how to manage the sickest of the sick patients with little resources, and really no backup, because everyone was just doing their best, and there wasn't really anyone's fault. We were just trying to survive. So I absolutely can see that when you're in that situation where people are just giving you these sick patients, you just got to do what you got to do and think about the consequences later, or just put up this wall. And that's what a lot of us had to do. We just had to put up the wall of no emotions and just get the job done.
Yeah. Well, Shona, first, as you expressed, thank you for doing this. Being at the front line, and Nadia, same to you. It's we can't comprehend. I only walked and watched and seen it, but being what you guys done, truly appreciate all the everything you've done for patients and everybody. So thank you for sharing. Let's go, guys. So let's go to the next slide. I wanna let's dive in. So I think let's take a quick look. I'll explain how to read this slide. This is the NIOSH WellBQ, okay? So we're just going to take a component of it, okay? And please note the NIOSH WellBQ as a survey has a lot of constructs. And as an example, on top, row number 1, you see question 1, and it's a job satisfaction question, okay? Please note that construct has 1 item on the survey. And all of those listed on this y-axis, they're all the ones that have 1 or maybe 2 items, and they are kind of easily processed into percentages, right? They have a scale, and we can be able to then process. And NIOSH gives very clear instructions in their guidebook of how to process the data when you are doing this. But you do need to divide them into kind of the category where there is a very clear, one construct, 1 item, versus a very complicated constructs, which will have multiple questions, involving, either summation, averaging, or some level of math to be able to arrive at the result, which is going to be an average and standard deviation. Here, it was a scale. So we were able to do something creative. So what you look here in this visualization, we're going to take those constructs, starting from job satisfaction, right, all the way, in this case, to question 67. And then you look at the percentages, and you have data for physician, and you see the kind of squares, which are filled in black, and the open ones. The filled ones are the positive. So for job satisfaction, if you look at the square location, that means that physicians, about 80% of them are satisfied with their job, and 20%, which is the square on the other side, are not the negative score. They're not satisfied. So that's how we divide it for all of them. Same for nurses, right? You see the other one on the right-hand side, the graph kind of follows the same logic. And I kind of divided this into these regions, 0 to 20, just for the visual perspective. And this would allow you to kind of, if it's 50-50, 50% of negative and 50% positive responses, you would find these data points to be in the middle. So as you look at it, you can look at the pattern, and you can see that those data points for both physician and nurses follow actually interestingly, very similar pattern, which allows you to kind of say that there are some similarities. From the p-value perspective, you can see at the bottom of the slide, I put 3 out of 23. There were only 3 data points here out of 23 listed that were different, right? And now I'm going to also point to these ones in a red box. And I'm going to kind of mention a few to you guys. What we're looking where the data cross, you can see the negative responses, for example, the open square and the kind of the open diamond. You can see the negative are on the right side. That's bad. That's a lot of people telling us that there is something bad happening, right? So you can see the crossing is occurring. And some of these things, come down to sexual harassment, physical violence, not sleeping well, the sleep quality, right? Drinking, so as we see not much differences in this data between physicians and nurses, we definitely can see some very worrisome data points about violence, the sexual harassment, again, not sleeping well, drinking too much. So I'll start with Nadia maybe here. And can we talk about it? Can we just have a conversation about it, about what is this telling us? What's the context?
Well, I think, Lucas, the first thing that I'd want to mention is, just in this data being presented to me and with my eyes, just taking it in for the first time, what stood out to me is just how much alignment there is in regards to the experience that's shared between our nurses and our physicians. When we think about culture, there is an unfortunate tendency where an us versus them culture can arise, and the nurse versus doctor, and I don't like using the word versus, right, because it shouldn't be an oppositional relationship, but is often perceived as such, just as, our folks on the front line versus, our C-suite leaders, the executive leadership. There tends to be these divides that exist. It's human nature. The grass is always greener. That tendency for comparison is just part of our makeup as humans. However, just this data alone just screams that experience is not the case. I think it's unfortunate, and Shauna, I won't speak too much here because I know our time is limited. But I do see that there often are just a lot of misalignment that occurs within just even our operations itself, when nurses are interacting with patients versus when the physicians are interacting with patients, often are on their own timelines, which feeds lots of breakdown in communication. And I think there can be then that tendency when there is that misalignment, that then there's at times that misrepresentation and a lack of kind of understanding from each other's perspective. As Shauna highlights, the situations in the rural hospitals, just as in the urban hospitals, these are complex scenarios, and there isn't a group out there that is flush with resource. We all share similar struggles in that regard. So when we think about a lot of the hardships that are endured when there's something that's right in front of us, then we can sometimes lean into that maybe a bit more than we typically would, which I think can be that us versus them. But I'll stop there. Shauna, I'd love to hear your thoughts here too.
Yes, Shauna, please go ahead. Nadia, thank you. I think that's a very important point you're making about kind of very, not really a big difference in this data. So I just do want to emphasize, I think that one thing we're seeing and you're emphasizing, because I think we need to come together. But Shauna, yes, we please kind of, want to take your take on it, on what do you see?
Yeah, thank you guys. I can kind of speak to the negatives of both the physicians and nurses, the ones that kind of are both negative. I think that a lot of this stuff, the sexual harassment, the physical violence, insomnia, that stuff happened before COVID anyways. I mean, just because when patients come into the hospital, they're not at their best. They're probably having some of the worst days of their lives. And that, that's kind of how we're trained and we're expected to see that. And I think that these numbers are now heightened now because with COVID, before nurses and doctors, they're some of the most trusted professions. That's just been known. We've just always been people, like the occupation that people trust. And then all of a sudden COVID hit and we were healthcare heroes for a while. But then all of a sudden we had this group of folks who decided that they did not trust anything that the medical community said anymore. And so I think that was really hard on the medical workers to be trusted and all of a sudden felt like we were the enemy. And it came across quite a bit with this physical violence and harassment. And that just went, up. I think it just increased exponentially after COVID. And people felt, I think, that they were able to say a little bit more things because of like the culture of the policies and the politics of the time. And so I think that just leads to, how do nurses and physicians cope? Well, during COVID, there was really not much you could do because you couldn't go outside and you couldn't do your normal coping mechanism. So alcohol was a very easy thing to lean on. And now that you've touched alcohol, it just is a rolling rock. It's just going to keep on going. It's hard to put that stuff down once you start it. So the sleep quality, insomnia, I think it's like a cyclical thing. And so that's why I believe that we're still trying to get out of that kind of stuff. We're still trying to be like, what are different ways that we can help our body and our minds and our emotions? And so that's why we're still, I think, seeing these high numbers.
Yeah. Now, both Nadia and Shona, thank you for sharing. This is it's a difficult topic, and there's a lot going on and to uncover. But looking at the time, I do want to make sure that we take questions from the audience. So I'm going to pause here. We had more to present. We knew that we can kind of go a little bit. We would love to do more of these presentations, but let us pause here at this moment. Maybe let's stop sharing the screen. And if we can look at the chat and open it up for any questions from the audience, we would love to take those and kind of go from there, as we have about 5 minutes left. So thank you guys for letting us present some of the data and talk through some of these challenges. So as I'm looking from the phone, I would appreciate if someone is able to monitor the chat, if there are any questions, or if anybody wants to raise their hand and ask the question, we'd love to take it.
Hey, Lucas, I was just pulling back up the chat. Yeah, there was one question in the chat, and I apologize. It's disappeared from my screen.
I can.
Okay, there
John,
we go.
I can.
Nancy, actually, if you'd like to ask it, it was regarding, sorry, trying to get this to expand so I can see it. There was the question of, regarding the data points, where these due to the difference due to work-life culture and worker and employee disconnect that you were discussing earlier.
So in relation to, could this be due to team cohesion and management style? And when I think about management style, also think about just leadership, right? Leadership development, leadership skills, and absolutely those are very much contributing factors. When we look at a lot of the data that we have, and I appreciated there's a comment lower down about some of the incredible work that's happening within the NCIOM task force, and looking at the North Carolina nursing shortage and recommendations that are coming out of that aligns. It looks like a lot of the data that you have aligns with what's been shared here. When we think about what are the strengths, one point in the data that I think is also important to point out, and we see this repeated in other inquiries, is one of the strengths is meaningfulness in work. So despite the circumstance, despite the animosity that had been felt, the conflict from so many different areas that extend much out of any of our environments, what has been a driving factor and a huge strength is that there is such significant meaningfulness. And what we see is that there is the tendency to have very strong, meaningful connection and cohesion at a team level. At a team, at a unit, at a division, in these smaller compartments, there's a lot of good and a lot of strength there to build upon. Now, yes, if a leader may not have a skill set that has been as developed as it could be, to put it in a nice way, that also impacts that unit cohesion, that ability for a team to really be able to come together. So that, is a huge factor when it comes to the perception of well-being, at least when folks are rating it in a, do I feel safe? Where I'm at this component of psychological safety as well, in their, front yard or backyard. Those are huge factors.
Thank you, Nadia. I was going to say we have about 2 minutes left. If each like to have any final comments. It's been a fantastic discussion on a very important issue. So I'll first go, Lucas.
Yeah, no, thank you, John. I just want to my initial is that I really, through this project, and I want to encourage everybody that both frameworks, I think, are extremely powerful frameworks, right? They can be used. As you can see, the first one that we show data that there is if you look at the rural and urban and kind of this association that, yes, there was less, as we showed you in the data, they can be trusted. I also want to comment that I'm very excited about the NIOSH WellBQ for the next few years, as we're going to get more data from other researchers and practitioners. and started to really build together as a community some benchmark, looking at interventions and how that data moved. It's a very holistic approach, and we need more data and we need more understanding. So I'm very excited about the tools and doing more work together. So thank you. Nadia, Shona?
Yeah.
I'll just express thanks for having the chance to join all today and agree this is incredible work that is in a constant state of evolution. Our goal is to develop best practice. How can we learn, and then how, of course, can we share?
Yeah, and just piggybacking off of that, I think that a lot of the stuff that we're talking about has been pretty negative, but with all the work that we are doing and all the changes that leadership is looking for and trying to push, I think that there is some hope, which is what we really need right now. And so that's where I'm excited about that.
Well, I think
And
that's
thank you for having us. We really were looking forward to this, and I appreciate the opportunity to share this with you guys very, very much. And thank you for joining.
Yeah, thank you for joining us today. Again, a great session. As you've seen here, as we are coming in the end, we've posted the QR code for the post evaluation survey, if you take that. And we've also put some information as far as where in the chat, the recording and slides will be posted on both websites, the Carolina Center and OSHR, as well as resources from NIOSH in terms of mental health for healthcare worker initiative and the NIOSH WellBQ. So again, thank you for joining us today, and have a great rest of your afternoon.